Outcomes in acute myeloid leukemia still remains poor, especially in older patients, despite several new agents approved in the last few years. I think there's a lot of excitement about new therapies, but still there's a major unmet need as far as going forward. So there were 3 different talks that were dedicated towards novel AML therapies. So the first one was on the differentiation, induction of differentiation, and there was highlighted a new approach of targeting GSK3 beta as a potential differentiation agent. However, there are no clinical grade inhibitors, so that's a limitation right now. So I think it still remains to be seen how we can use that approach in the clinical space. The second talk was by me, looking at the approaches of targeting cell death. I discussed combination strategies, how to make the combination of hypomethylating agents, venetoclax, better. So in particular, adding the targeted agents such as FLT3 IDH inhibitors in the so-called triplet approach, when we add something towards the therapy that is already established. And then using the immune therapy, and the example I used was anti-CD47 antibody to engage macrophages and combine with azacitidine venetoclax. And at the end of my talk, I highlighted the role of BCL-XL in some of the lymphoid malignancies, and also mentioned ongoing work in AML. And finally, the last talk of that session was focusing on the NK therapies, immune therapies, given by Todd Fenninger from Washington University. I have not heard his talk before, so this was really exciting for me. So they're generating what they call memory-like NK cells by exposing NK cells to specific subsets of cytokines in culture, and then infusing them in the patient. And they showed that this memory-like NK cells, they expand like 1,000-fold, and they also can persist for at least a month. If they're allogenic or if they're autologous, they can persist for a long time. Of course, in AML, autologous NK cells probably not a great idea, as we talked in discussion, but allogenic approach is still very important. And so they use this memory-like NK cells in the setting in combination with stem cell transplantation. They also use IL-15 to stimulate the NK cells in vivo, and the results seem to be quite promising. They also identify the phenotypes of these NK cells and some of the tumor suppressive antigens such as NKG2A that, if modulated, can make these NK cells more potent. So I think that's a potential therapy. Certainly, I think CAR T cells have not yet made that dent in AML. The trials are still ongoing, but so far we haven't had great successes. I think people are really now looking into NK cells as cellular therapies in AML, which are safer and perhaps more feasible, more efficacious, but they have to be modified in a way to make them more potent, more active against the tumor cells. Of course, some of the responses were not durable, so the question is how to make them more durable and more potent. So I think this was a great discussion. Then, and there was a question from the audience how you combine the approaches, right? So like venetoclax-based therapies and cellular therapies. So we don't know at this point, but there was a recent work from Tony Letai's group that showed that venetoclax does not hurt NK cells, and in fact the NK cells are spared from venetoclax toxicity, and the combination perhaps even makes it better as far as killing. So I think that's hopefully the future where we can use all the tools we have, because AML is just such a hard to treat disease with multi-clonal nature of leukemia and escape mechanism that are almost inevitable unless you do the combinations. And of course, the combination has to be safe and effective. So that's kind of where we stand right now.